Welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and I'm delighted to be here with my colleagues.
I'm Rhiannon Ashman.
And I'm Sangeeta Krishnan.
Today we'll be discussing ear problems. Our GP advisor, Dr. Ravi Ramanathan, recently told us that ENT, or ear, nose and throat, is one of the key topics that newly qualified GPs need to consolidate. So we hope to offer some key points for experienced and less experienced GPs based on great CPD that we have on MIMS Learning. So let's start away. I wanted to look at hearing loss first, as we have some learning resources on this topic, and it is extraordinarily prevalent. According to the RNID charity, 1 in 3 adults in the UK are either deaf, have hearing loss or tinnitus, and over half the population aged 55 or over have hearing loss. This rises to 80% of people over the age of 70. We'll get to tinnitus later, but staying with hearing loss for now, not only does it have an impact on people's daily lives, but it's also a substantial risk factor for dementia. You may or may not be aware of the Lancet Commission on Dementia Prevention, Intervention and Care. It has, in its 2024 update, listed 14 modifiable risk factors for dementia, which include hearing loss. Hearing loss is identified as a midlife risk factor, and there would be a potential reduction in up to 7% of cases of dementia if this risk factor could be eliminated. So the Lancet Commission rates hearing loss as similar in importance to raised LDL cholesterol in terms of dementia prevention, and more important than other factors such as diabetes, smoking and obesity.
That's a surprising one to me. I would not have thought of hearing loss as a risk factor, given how common it is among older people.
Yeah, I'm staggered by that as well. The factors I'd have thought of would be things like social isolation, depression, and that sort of thing. These are all included, but none of them as significant in terms of risk reduction as hearing loss. And with an ageing population, dementia is obviously on the rise.
Absolutely. And so leading on from this, our GP advisor, Ravi, discussed some research from the British Journal of General Practice on the GP's role in discussing these dementia risk factors. And the researchers felt that there was a lot of potential for GPs to make a difference by discussing risk factors. Ravi thought that the bit about hearing loss was particularly important, and for him this was a key takeaway of the study, as it's something he felt he could actually influence. So he could actively ask more patients about hearing loss and refer them for hearing aids earlier.
That's a very practical point and something for GPs to consider. Obviously, older patients may have age-related hearing loss, but there are a lot of other reasons why it might become more difficult for people to hear. These are listed in a red flags module on hearing loss by Dr. Pipin Singh that we touched upon in a previous episode briefly. Let's talk about conductive hearing loss first. This happens because some kind of blockage prevents sound waves from reaching the inner ear. Causes can include earwax, otitis media, otitis externa, otosclerosis, or a postnasal space tumor.
Can we focus on otitis externa for a time? It's quite common, with apparently 1 in 10 of us affected by it at some point in our lives.
That's right. So as a reminder, otitis externa is an infection of the external ear canal skin, which can extend to the external ear and tympanic membrane. A clinical review on otitis externa by Miss Natalia Glibbery and colleagues noted that the annual prevalence of otitis externa in the UK is 1%, with the peak incidence being in children aged 7 to 12 years. So predisposing factors to this condition include eczema or seborrheic dermatitis, along with atopy and non-atopic allergy. Active chronic otitis media or glue ear might also be a predisposing factor. It's usually caused by Staph aureus or Pseudomonas aeruginosa, but in 10% of cases there'll be a fungal infection, so taking a swab is advised.
And what symptoms might your patients have?
So they might have ear discomfort, itching, discharge and conductive hearing impairment, but may also have severe pain, occlusive swelling of the canal and cellulitis of the surrounding skin. They may also be systemically unwell in more severe cases. And you can classify the severity of otitis externa using the Brighton grading scheme, with grade 1 being the least severe and grade 4 being the most severe. So grade 1 describes localised inflammation. In grade 2, there's debris in the ear. Grade 3, the ear canal is occluded. And in grade 4, you would see perichondritis and perhaps systemic illness. And you can find a link to this in the clinical review module on our website, mimslearning.co.uk.
And what are the recommendations regarding treatment?
So the management options are laid out in a handy table in the module. But to summarise, antibiotics are the mainstay, or antifungal therapy if it's a fungal infection in grades 1 to 3. In grade 3, if there's complete canal occlusion, you should refer to ENT, while in grade 4, a same-day ENT referral is required because the patient might need admission and IV antibiotics. And there's a table on what to prescribe in terms of topical preparations. So antibiotic ear drops containing a quinolone or aminoglycoside antibiotic are usually given for up to 7 to 14 days. But antifungal drops with clotrimazole are continued 2 weeks after resolution of symptoms. Aminoglycosides are potentially ototoxic, so if a tympanic membrane perforation can't be ruled out, ciprofloxacin can be used as a first-line therapy, according to Miss Glibbery. All antibiotics should only be given to people with severe infection or high-risk groups, such as those with diabetes or immunosuppression. However, there may be people whose otitis externa does not improve within 48 to 72 hours, and who might require urgent ENT referral. The complications can include recurrent infection, abscess formation, spreading cellulitis, or tympanic membrane perforation.
And that brings us to the possibility of necrotizing otitis externa, which is a major red flag as it is a life-threatening emergency. But when should you suspect this?
Well, we were talked through this in person earlier this year. Dr. Rakesh Chopra, who's a GP and a very experienced ENT trainer, gave a great presentation on ENT emergencies at MIMS Learning Live in London 2024. He said that necrotizing otitis externa used to be called malignant otitis externa because it behaves like a malignant pathology, although it's not actually malignant. Dr. Chopra stressed that this is a medical emergency and has a 10 to 20% mortality. His exact words were, if you have elderly, debilitated, frail, diabetic people who start having severe earache with blood-stained discharge, and you look in with an otoscope and you see granulations at the floor of the auditory canal, you have to pick up the phone or send them to A&E. Our free conference report about Dr. Chopra's talk has a concise box listing when to suspect necrotizing otitis externa. This covers signs and symptoms like unremitting pain, fever, malaise, or otorrhea, granulation tissue or exposed bone in the ear canal, temperature of over 39 degrees Celsius, and the presence of diabetes or a compromised immune system. You can find this list within our free conference report.
Oh, that's really good specific advice for GPs, particularly as an estimated 5.6 million people in the UK are now living with diabetes. And finally, on the subject of conductive hearing loss, it's also very much worth mentioning another 2 red flags. Firstly, consider a cholesteatoma in people who have a watery discharge from one ear and gradual loss of hearing. Second, consider a post-nasal space tumour in people with persistent and unexplained conductive hearing loss. Your alarm bells should ring if your patient is of Chinese or Southeast Asian family origin and has persistent ear effusion, as this population has a higher risk of nasopharyngeal cancer. So we've had some discussions now about conductive hearing loss, but of course the most common type of hearing loss is sensorineural hearing loss. This is related to damage to the hair cells in the inner ear, or sometimes the auditory nerve. It can be caused by aging, exposure to loud noise, medications, Meniere's disease, and barotrauma. It's worth also considering more serious possible causes such as multiple sclerosis, acoustic neuroma, or a vascular event.
Sudden onset of sensorineural hearing loss is a red flag to look out for. In his conference presentation, Dr. Chopra said the incidence of sudden onset sensorineural hearing loss is on the rise, although it's not clear why. He said that if your patient has suddenly lost their hearing in less than a 3-day period and they come to see you within the month, it should prompt immediate referral to an ENT or emergency department so that the patient can be seen within 24 hours.
Yeah, and it's perhaps worth reiterating that immediate ENT referral is also indicated in cases of new unilateral hearing loss associated with facial droop or altered sensation on the same side, or referral to a stroke service if stroke is suspected.
Presumably there are still other red flags to look for even if the onset of sensorineural hearing loss is more gradual?
Yeah, and as Dr. Pippin Singh's red flags module points out, unilateral progressive sensorineural hearing loss, especially if it's associated with tinnitus or vertigo, needs to be referred to exclude an acoustic neuroma. And we talked about drug-induced hearing loss in a previous podcast discussion, but it's probably worth saying again that we have a list of ototoxic drugs ranging from chemotherapy to NSAIDs in our red flags module.
Great. Okay, so let's move on because there are some other key things to cover. There's another important general ENT red flag to watch out for that's mentioned by Dr. Chopra, isn't there, Sangeeta?
Yes, Dr. Chopra talked about acute mastoiditis, which he says is not commonly seen, but it's essential to know about. This infection affects the mastoid air cells and is characterized by otalgia and a tender mastoid process. It can be accompanied by blunting of the post-auricular sulcus. In 10% of patients, a normal tympanic membrane can be seen. According to the NHS website, people are more likely to get mastoiditis if they have a severe ear infection or get loads of ear infections. So that's something to watch out for. Then there are foreign bodies. Dr. Chopra reminds us that a battery anywhere in the body is an emergency and that children may put objects into their ears as well as their noses and mouths. He said that it's not a good idea to try and grasp round foreign bodies, as you might just end up pushing them further in. And it's also not a good idea to irrigate organic foreign bodies like peas, as these can absorb water and swell.
Yeah, constant fear for most parents, I assume, is your kids putting something in their bodies that they shouldn't.
Yep, many of us have been there in A&E, having a scan to see where something's got to. So finally, let's have a look at tinnitus, which is a common and potentially very debilitating ear condition.
Yeah, it is a very common ear complaint, with at least 15% of the world's population experiencing it at some stage of their life. So people affected can hear sounds without the presence of an external stimulus. And we have a red flags module specifically on this, updated by Dr. Pippin Singh. It lists some red flags to be aware of in presentations of tinnitus. Anyone care to take a guess what one might be?
Perhaps chest pain?
I was thinking auditory hallucinations alongside tinnitus could suggest psychosis.
Yeah, close. The red flags listed are recent head injury, significant neurological symptoms or signs, severe functional or psychological distress, severe vertigo, sudden unexplained hearing loss, sudden and pulsatile tinnitus, and unilateral tinnitus. So it's important to arrange urgent referral if you spot any of these. And in the rare case where you can hear the tinnitus as well as the patient, that's another red flag for urgent specialist attention.
So what do people hear when they have tinnitus?
Well, people hear a variety of sounds when they have tinnitus, ranging from whistling, humming, pulsating, or clicking sounds to a mixture of these. And it's interesting, actually, because my husband had sudden onset tinnitus a few weeks ago, and we were really worried about it because he was describing it as a pulsatile tinnitus, which, as we've just heard, is a red flag. And it was only on careful questioning by the GP that actually he was able to articulate more what it sounded like, a kind of popping sound. Some people described it as being like butterflies fluttering in their ears, we read online. So I think what I took from that was that it might really require careful questioning to help patients to articulate exactly what they can hear, because it is quite a subjective experience, I think, when you've got tinnitus.
Yeah. And I actually came across some sounds created by the British Tinnitus Association that you can play to get an idea of sounds people hear. So I'm just going to play 3 of these because they're really quite different. So here comes number 1. That's number 1. And then number 2 is much more high-pitched. First one was more like static, I thought, and then the third one, there are more that you can play. You can go to the website and listen to them. The third one is more what you might call pulsatile. So there is a really big range of what people might experience.
Yeah, and of course, really distressing, I can imagine, to have that noise constantly.
Yeah, it sounds really intense, especially the second one.
Yeah.
And I can imagine how that might affect your peace of mind. So what causes tinnitus?
So there are a lot of causes. Noise exposure and hearing loss are the most common, as you might expect, but also earwax, head injury, infections and medications can lead to tinnitus that is sometimes reversible.
Which medications might be implicated in this?
Aspirin, diuretics and certain antibiotics, such as erythromycin and tetracycline, have been implicated. Also, apparently there's a link between tinnitus and certain metabolic conditions, such as thyroid disorder or B12 deficiency. And pulsatile tinnitus may indicate a vascular malformation, an obstruction in the carotid artery, or a glomus tumour. Occasionally, it's accompanied by hyperacusis, which is an exaggerated perception of certain sounds, and which typically indicates cochlear damage.
And Sangeeta, can you talk us through some of the management options?
Yeah, sure. So apparently, some reversible causes of tinnitus can be managed in primary care, like impacted wax, medications, side effects, and otitis media or otitis externa. Chronic tinnitus often improves with time because people do get used to it. And in the meantime, there are measures that they can take to reduce its effect on their life. For example, tinnitus is naturally masked by background noise, so quiet music, the sound of a fan, or a water feature can improve tinnitus. Hearing aids, sound maskers, and sound therapy can also be effective. Stress, anxiety, and fatigue can worsen tinnitus, so relaxation techniques and for some antidepressants may be useful. The Red Flags module recommends against patients trying expensive and unproven treatments and instead signposts people to the Tinnitus UK charity. Some specialist clinics may be able to offer tinnitus retraining therapy combined with psychological support to reduce feelings of anxiety, anger, and hopelessness. Tinnitus can be very distressing. We've already listened to those sounds that Pat played for us, and I think we can all agree that tinnitus can be very distressing. I remember this story from a few years ago when there was a case of a woman in the Netherlands called Gabby Olthius, and she had tinnitus that was so unbearable that she was granted assisted dying.
I didn't actually hear about that. Could you tell us a bit more?
Yeah, so there was a lot of uproar basically, and that's why it was in the news. And the clinic that approved it was subjected to scrutiny by public prosecution and the health ministry in the Netherlands. The question was whether was assisted dying really necessary for Gabby. So the independent commission that reviewed Gabby's case, they maintained that the extreme tinnitus may be a valid reason to warrant the assisted dying, but that Gabby's case should have undergone further psychiatric research. And then the clinic's director said that though Gabby was suffering physically and that it was not a psychiatric problem. Gabby's family spoke about the invisible nature of her suffering.
Yeah, that's really interesting because obviously this is very subjective because nobody else could have heard what she was hearing. Very difficult to determine what constitutes suffering that justifies assisted dying in that case.
The podcast Talking General Practice actually have an episode where they discuss assisted dying. That's an interesting listen.
Yeah, a really good listen. I had listened to that and definitely worth checking out. So, yeah, well, thanks very much for that, Sangeeta and Rhiannon. It's great to know that there is some support for patients in what must be a really hard to live with condition. So, what have we learned today? I feel like I've learned a lot. Firstly, we've learnt that in the context of dementia prevention, maintaining your hearing is really very important. So, as Dr. Ravi Ramanathan advises, it may be time to ask more patients about whether they're experiencing hearing loss and considering, where relevant, whether they need a referral for a hearing aid. Second, don't forget the red flag symptoms and signs of necrotizing otitis externa. Experienced GP and ENT trainer Dr. Rakesh Chopra reminds GPs that they should suspect this and contact A&E if their patient with otitis externa is older, has diabetes, has a fever of over 39 degrees, has unremitting pain, and you can see either granulation tissue or exposed bone in the ear canal. And thirdly, the range of sounds heard by people with tinnitus is perhaps wider than you might expect. These might be humming, clicking, or pulsating sounds. It's not surprising at all that tinnitus has a detrimental effect on patients' lives, so it's important to eliminate reversible causes such as medication that causes tinnitus and to provide signposts to sources of help such as the Tinnitus UK charity. Don't forget you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Thanks for listening. We've been the MIMS Learning editorial team, and this episode was produced by Inga Marsden and Till Owen. Next week, tune in for a discussion about POTS, or postural tachycardia syndrome, between Dawn Liz Powell and Professor Leslie Cavey, who's a GP and chair of the POTS UK charity. See you then.